So our first speaker will be Sara Kohlbeck, who's the Assistant Director of the Comprehensive Injury Center at the Medical College of Wisconsin. She'll lead us off with an overview of national and state data on suicide, both broadly and with some additional information on youth and young adults. So Sara, appreciate it, and take it away. Thank you.
Thanks, Sam, and thanks for having me today. Again, my name is Sara Kohlbeck. I'm the Assistant Director of the Comprehensive Injury Center at the Medical College of Wisconsin in Milwaukee, Wisconsin. And as Sam alluded to, I am going to be kind of taking the 30,000-foot view to talk about suicide in Wisconsin, looking at a variety of data across demographics, across age groups, and different circumstances around suicide in Wisconsin to frame our discussion today. Before I get started, I would just like to provide some acknowledgement for Pamela Im. She's an epidemiologist with the Division of Public Health at the State of Wisconsin Department of Health Services. Pamela was instrumental in helping me compile this presentation and in providing some of the information on self-harm that we'll see towards the end of this presentation today. And just some real quick information about our center and our collaboration with the Department of Health Services. We do collaborate with the department on a number of initiatives. One particular initiative that I would like to highlight as part of this presentation today is the Burden of Suicide report. There have been two Burden of Suicide in Wisconsin reports that have been released, one in 2008 and one in 2014. We are currently working on a third installment of this report, which will be released in May of 2019. I don't think it's going to be called the Burden of Suicide report. I think we're likely going to call it something different. But that report will have additional surveillance information on suicide in Wisconsin for community members and legislators. All right, so to get started, as I said, I will be providing a brief summary of kind of the picture of suicide in the state of Wisconsin. I'm going to be looking at 13 years of data, so 2004 through 2016 as part of this summary. And there are a couple of data sources that I use in this summary. The main data source is the Wisconsin Violent Death Reporting System, and I believe that you all have a handout on this reporting system in your folders. But basically what this system does, it's a part of a larger national violent death reporting system that's hosted by the CDC. And this system collects information on suicides, homicides, violent deaths of undetermined intent, and also unintentional firearm deaths. And the way that the system collects this information is by looking at death scene investigations from coroners, medical examiners, as well as law enforcement. And information is entered into the system, including circumstantial information. There's toxicology information. There's information on sort of the mechanism of injury or weapon types used in these violent events. This information is all available online. If you're interested, you can just Google Wisconsin Violent Death Reporting System and find information there. The self-harm data that I'm going to be looking at is provided from healthcare data, which has been obtained from the Wisconsin Hospital Inpatient Discharge and Wisconsin Hospital Emergency Department visits through the Wisconsin Hospital Association. And again, all of this information is available through the Wisconsin Department of Health Services Office of Health Informatics. So here are the number of suicides from 2004 through 2016. You can see charted along the line here each number for each year, starting out with 642 deaths in the year 2004, and then increasing. You'll see kind of an increasing trend over the 13-year time period that we're looking at here. A slight decrease in 2014, but then an increase again in 2015 and 2016, with 846 lives lost to suicide in the year 2016. So in terms of looking at the age of suicide decedents, you see two different figures here. So the graph at the top is showing the percentage of suicide among all suicides, and you see kind of a bell curve here. The highest percentage of suicides by age group occurred among those who are ages 40 to 49. If we look at the bottom set of information, those are suicide rates. Basically what rates do is they take the number of deaths and then divide it by the number of total people that are in each of these age groups, and then multiply that number times 100,000. And that's sort of a method of standardizing health information so that we can compare different groups. And you can see this in this information as well. The age groups that bear the highest burden of suicide are those ages 35 to 55. I can tell you that this is consistent with national data. The national suicide rates are highest among the 45 to 54-year-old age group. I believe the national rate for that age group for this time period is 18.9 per 100,000. In terms of race of suicide decedents, the largest percentage of those who died by suicide in Wisconsin during this time period were male, white, and non-Hispanic. However, if we look at this information in terms of suicide rates by race, we actually see that American Indians in Wisconsin have the highest suicide rate by racial group, higher than whites, Asians, and any other race ethnicity group in the state of Wisconsin. In terms of mechanism of injury or cause of suicide death, the most prevalent form of weapon used in suicide deaths in Wisconsin was firearm, followed by suffocation, which is hanging, poisoning, which would include alcohol poisoning, opioid poisoning, other types of drug poisoning, and then other, included in other are things like motor vehicle crash, drowning, falls, things of that nature. Education level of deceased. The majority of decedents from suicide had a high school diploma, although almost a third did have a college degree. 9.2% had some college, which means that they attended college but did not have a college degree. And then roughly 16% of decedents had less than a high school education. And when I say college degree for that 29.2%, that's associate, bachelor's, master's, and professional degree included in that group. This slide is just an overview of some characteristics of suicide decedents, and really the intent of this slide is just to demonstrate how complex this issue is. As Representative Ballweg alluded to, suicide is a very complex phenomenon. Just as there's no one type of cancer, there's really no one type or typology of suicide. It is a very complex phenomenon. As you can see here, approximately 18% of decedents during this time period either were currently serving in the armed forces or were veterans of service during their lifetime. 32% were married at the time of death. 6% of decedents were recently released from hospitals, specifically within the 1 month prior to the suicide, which is salient for policy discussions around recent release from a medical facility. 48% of decedents were in a relationship at the time of death, and 1% were homeless at the time of death. As I said, suicide is a very complex phenomenon, but the Wisconsin Violent Death Reporting System does provide us some information, some clues into some of the circumstances that were happening in folks' lives before they took their life by suicide. I think for this group, in our discussion of youth and young people, an interesting factor is that among those that were deceased that were between the ages of 10 and 24, roughly a quarter of those students had school problems that were thought to have contributed to the suicide. And again, that's information that's provided to us from coroners, medical examiners, and from law enforcement who are getting that information from family members, from friends and loved ones. So this is information that's coming from that source. Roughly 50% of decedents had a documented mental health problem, which also means that roughly half of the folks that were in this group of decedents did not have a documented mental health problem. A third of the deaths were reported to be related to an intimate partner problem. In 8% of all of the suicides occurring in this time period, an argument or conflict appeared to contribute to the death by suicide, and a majority of those conflicts occurred within 24 hours of the suicide event. So this was a crisis situation where a person was having a conflict with another person and then died by suicide within 24 hours. And then in 20% of the suicides, a job problem appeared to contribute to the death, and that could be recently losing a job, disciplinary action on a job, or having other job problems. In terms of kind of potential precursors or clues to suicide, 32% of those who died had disclosed their suicidal intent to a friend or loved one in the month prior to the suicide death, which speaks to the need to ask, and then if somebody expresses intent to you, to do something about that. About a quarter of the deceased had a history of suicide attempts. 40% of the deceased left a suicide note. And then in 3% of the suicides, the recent suicide of a friend or family member appeared to have contributed to the suicide. And there was a higher percentage found among youth and young people ages 10 to 16. So this sort of speaks to that copycat phenomenon around suicides in younger people, that it's very important to be careful in that time after the suicide of a young person to watch the young people around that young person for potential suicidality. The next thing I'm going to look at is self-inflicted injury. We know that in terms of the phenomenon of suicide, the suicide deaths are really just the tip of the iceberg. We know that for every suicide death, there are a number of people who have attempted suicide, who have had suicidal ideation, who have thought about suicide, and a number of people who have had plans for suicide. And so in order to prevent those deaths, it's really important to think about kind of the beneath the surface of the water components of this phenomenon in order to address and prevent the issue. We know that having a history of suicide attempts is definitely a risk factor for suicide, but we also know that not all instances of self-inflicted injury are indicative of suicidal intent. We do know that there is a phenomenon called non-suicidal self-injury, in which a person harms him or herself without the intent to die. So it's really important when we're thinking about this self-harm information to sort of keep that in mind, that although we definitely don't want people hurting each other and going to the emergency department or the hospital, that not all of these instances of self-injury are indicative of suicidal intent. So just some information on emergency department visits for self-inflicted injury. Again, this comes from Wisconsin hospital information. These are individuals who were treated in the emergency department and released only. So this does not include individuals who were admitted to the hospital or who died in the emergency department. These are individuals who were released from the emergency department. Again, these are rates, not percentages. They are age adjusted to the 2000 US Census, and all rates are per 100,000. There were a total of 3,743 visits for self-inflicted injury to emergency departments in Wisconsin in 2015. And among all of the years that you see here, females ages 15 to 24 had the highest rates of self-inflicted injury. You can see that females have the highest rate of self-inflicted injury overall, but that age group of 15 to 24 years is particularly affected by this. And we have similar information for the hospitalizations for self-inflicted injury. So these are non-fatal self-injury hospitalizations only. So folks that are admitted to the hospital and then released from the hospital. Again, you can see for the time period that we're looking at, females have the highest rates of hospitalizations for self-inflicted injury. There were over 5,600 total hospitalizations, non-fatal hospitalizations in 2015. And again, females ages 15 to 24 are particularly affected for self-inflicted injury hospitalizations. There's going to be more information that's going to be presented by our colleagues from the Department of Public Instruction on sort of suicidal plans and suicide ideation among young folks, so I won't spend time talking about that. But what I do just want to briefly touch on in the last few minutes that I have here are some ideas for suicide prevention. There are evidence-based policies and programs that are available. They're grouped into a couple of different categories. One is educational programs, and Representative Ballwig mentioned the QPR program, which is an educational gatekeeper training that's for all audiences. And then there are other educational programs that are targeted for other groups, including elementary, middle, and high school groups. There's also an educational kind of gatekeeper training program that's specifically for military families. That's called the Cognito Family of Heroes. Again, that's an evidence-based educational program for suicide prevention. There are also evidence-based treatment programs for suicide prevention. These are typically undertaken by counselors, social workers, therapists. When folks are going into clinic settings, they are receiving these type of treatment programs that are evidence-based for suicide prevention. In terms of policy considerations, the CDC has provided, as you can see here, 7 recommendations for policy change to prevent suicide. One piece that I would like to highlight that's specifically relevant to this topic that we're talking about is number 5, teaching coping and problem-solving skills in schools. One project that I'm currently working on in Jackson County, Wisconsin. Jackson County has a relatively high rate of suicide among young males ages 18 to 24. What that county is currently doing is implementing mindfulness-based stress reduction type programming into its high schools in order to provide young men and women with sort of the tools for coping and resiliency, so that when they are kind of reaching that age group of 18 to 24 years old, they have the tools that they need in order to cope with stressful situations. And that's a way to kind of move a little bit upstream and hopefully prevent suicide from occurring among that age group, and then among other age groups as well. Just as I wrap up my slides, I would like to recognize the two quality specialists. So the Wisconsin Violent Death Reporting System, as I said, is information from a couple of different sources. There are two individuals who are in the Department of Health Services that actually look at that information and then put all of that information into the system for researchers like myself to utilize. Kitty Clement and Kim Voss at the Department of Health Services. I would just like to recognize them for their work on this reporting system. It's very important information for us who are trying to do this work in prevention. And again, my name is Sara Kohlbeck. This is my contact information. There is going to be a question period, but if you need my contact information and want to follow up after this event today, you're welcome to do so.